Good afternoon, everyone, and welcome to today's webinar, Renewed Focus on Billing and Reimbursement, Optimizing Revenue Cycle During COVID Challenges. For months, healthcare organizations have endured downturns in elective procedures, admissions, and office visits, and witnessed similar declines in their overall margins. However, those successfully weathering the storm are using technology to protect existing revenue streams, uncover inefficiencies, and adjust to business needs in real time. That's the focus of today's panel discussion. Hospital and physician group experts will share how they've successfully adapted to declining revenue. They will also examine the role of the latest technologies in delivering insights that help them proactively manage their organization's performance. We will begin today's webinar with a presentation, and we will have time at the end of the hour for a question and answer session. And you guys can submit any questions you have throughout the webinar by typing them into the Q&A box that you see on your screen. We will also have a series of audience polling questions, and so as soon as the poll questions pop up, you'll get an automatic notification on your dashboard. And when the poll question launches, just please select an answer from the options on your screen and click Submit, and we thank you in advance for your participation. This session is being recorded and will be available after the event today, and you can use the same link that you used to log into today's webinar to access the recording. And with that, I'd like to introduce our panelists for today. So first we have Dr. Dennis Durrell, who is the Executive Director of Hospital Medicine with American Physician Partners in Nashville, Tennessee. He supports the management of APP's hospital medicine program and provides clinical oversight to its hospital medicine physicians and advanced practice clinicians in support of the company's ongoing quality efforts. Dr. Durrell has over 15 years of hospital medicine leadership experience, having served as the owner of a private hospital medicine practice and CEO and founder of a boutique healthcare consulting company. Derek Perkins is a revenue cycle leader with over 23 years of experience working with large health systems across the country. He has performed successful revenue cycle optimization projects at Ascension Healthcare, Allina Health, LifePoint, Christus Health, and oversaw the unprecedented growth of the Memorial Hermann Medical Group from less than 200 providers to over 800 providers. Mr. Perkins is the founder of Medis Advisors, a consulting that improves the financial health of rural and smaller practices through revenue cycle optimization and recovery. Lynn Mettler, our moderator, serves as the Client Delivery Officer of Ingenious Med, a provider of easily implementable mobile and web solutions that improve physician productivity and hospital performance at the point of care. He is responsible for development, infrastructure, integration, support, and application engineering of Ingenious Med solutions. Mr. Mettler has more than 20 years of experience developing and delivering complex software solutions in the healthcare, digital publishing, and telecom industries. And now I will hand it over to Lynn to begin the presentation today. Lynn?
Thank you so much. Good afternoon. As Abby mentioned, my name is Lynn Mettler. I'm honored to be your moderator this afternoon. On behalf of the entire Ingenious Med team, I would like to thank you for taking out time out of your busy schedules to join us for this panel discussion. I'm very excited to share the virtual stage with two amazing speakers today. I'm looking forward to their insight and their perspectives. So with that, let's dive right in. Next slide, please. One more slide, please. All right, perfect. Nothing on this slide will surprise you as you live this every single day. Even before COVID-19 hit, hospitals were struggling to make ends meet. Declining reimbursements have put pressure on margins for years. Recent data from Kaufman Hall shows that on average, hospitals were operating on 3% margins even before the impacts of COVID. About a third of hospitals were running an operating deficit. This is a very challenging environment, to say the least. Then COVID struck and made a difficult operating environment significantly worse. Volumes dropped as hospitals tried to free up emergency capacity, bracing for a surge of ER and ICU patients. Healthcare consumers deferred elective procedures, the very procedures that often prop up operating margins at hospitals. With the pandemic unfolding, average operating margins dropped to -3, and now half of all hospitals are running below break even. Without additional financial support, margins are predicted to erode even further. Next slide, please. Independent data shows that surgical volumes declined an astonishing 61%, and discharges dropped by more than 30% after COVID started. In reviewing our own data, we saw a significant decline in bill volume on the platform starting in March. IngeniusMed is a broadly used solution and is a core component of the revenue cycle at 7 out of the 10 largest health systems and physician management companies. As a result, our data is a good representation of the healthcare sector as a whole. Volumes began to recover somewhat in the summer, but are now showing a second decline as new cases begin to spike again. Ultimately, we're still significantly down on volume from pre-COVID levels, adding to the financial challenges hospitals face right now. So with that, I'd like to move into a poll question. I want to take a quick poll of our attendees about the issues raised with these statistics. If you could optimize one aspect of your organization, what would have the biggest effect on staying viable in the next few months? Is it physician and staff productivity? Is it revenue capture? Or is it reimbursement processes? So let's pause for about 30 seconds so we can collect your responses. We'll publish the results of this poll and an analysis of today's discussion on the IngeniusMed blog in the next few weeks. We'll give it just a few more seconds. All right, let's move into the panel discussion portion of our webinar, now covering, amongst other things, strategies for optimizing productivity and revenue amid changing volumes, shifting case mix and length of stay, and adapting to impacts on reimbursement and delivery models. Next slide, please. Our panelists today are healthcare experts on the front line of the pandemic. They will share with us how they've successfully adapted to declining revenue. They will also examine the role of technology in delivering insights that help them proactively manage their organization's performance. With that, let's move right into the first question. Our first area of focus today centers around optimizing productivity. What challenges did COVID-19 present for managing physician productivity, and how did you respond to them? Let's begin the discussion with Dr. Durrell today.
Thank you, Lynn. Well, obviously, we were very much surprised in the worst pandemic in our lifetime that our volume would drop and not go up. But in our company, across 19 states, with our contracts for emergency medicine, hospital medicine, and intensive care, on the emergency side, our volume dropped approximately 50%, and on the hospital medicine side, about 35%. And so for our large physician practice, that revenue drop had to be met with changes. And in hospital medicine in particular, it's been a challenge to staff to volume on a daily basis. We tend to have fixed schedules. Some days we don't have enough staff, and other days we have too much staff, and then occasionally we get Goldilocks staffing, which is just right. The COVID pandemic made us staff in a flexible way to volume every single day. And in order to do that, we had to understand our volume in real time. And so IngeniusMed, our billing capture platform, we were able to know at the end of a day how many patients we had. We could project accurately, pretty accurately, what we'd have the next day. And by adjusting staffing on a grid, we were able to match our workforce with the reduced volume. And we were also able to see how many patients had COVID due to flags that flagged COVID patients. And so we were able to factor that into the burden of work that each patient would require. And so being nimble and having real-time data on our patient list and patient encounters and having reports that could show us that very quickly was very helpful for us matching volume to staffing. And that's how we were able to really weather the storm through this difficult time.
Great insights. Derek, what are your thoughts on this topic?
Hey guys, thanks for having me today. So I'm wearing two hats today. One would be the Memorial Hermann hat of the ABP or revenue cycle to talk about some of the lessons learned. And the other hat would be some of the best practice strategies I have for my clients with the Metis advisors. Memorial Hermann, for those who don't know, is the largest health system in Houston, Texas. So we were severely impacted by COVID, to say the least. Our loss was upwards of $620 million. And a lot of that was due to most health systems with the reduction in elective procedures. The medical group saw in April a 67% reduction in charges, and it was led by our primary care business, of course. So patients did not feel comfortable going into our clinics for elective procedures. We did also see a decline in all specialties, including our hospitalists and urgent cares. What we did on the physician perspective, though, is we actually revamped their bonus productivity goals. We knew that was going to be an issue when you have less patients coming in. So we took that off the table right off the bat, and we pretty much revised the goals for each specialty. But to be totally honest, we did have an opportunity to breathe a little bit in terms of the revenue cycle piece. So we were down, understaffed by over 50 plus FTEs. So we used that as an opportunity to catch up. In particular, our coding backlog. Although COVID presented some new challenges, our coders were able to kind of catch up on some of the smaller balances and some of the claims that have been lingering. We definitely used IngeniousMed to make sure all our charges were captured at the point of service. Previous to IngeniousMed, we were having manual charge entry, which of course always lends itself to possible missing charges, charge delays, which also increases the AR. But we also took a step back and we sharpened our pencils a little bit, and we looked at everything, including our scrubber and our edits. We found that we had edits that had been in place since the beginning of time. So we used that to eliminate some of the edits we no longer needed. And finally, we just looked at our denials and our appeals, and we focused on making sure our staff was able to appeal some of those lower balances that we normally could not get to. So overall, COVID was not good for the health system as a whole, but it did allow our revenue cycle team to at least catch up on some of the outstanding AR.
Thank you. I like how both of you leveraged analytics and KPIs to gain the insights needed to manage through these times, or in other words, going back to basics on execution. So let's stay on this topic for our next question as well. COVID has significantly impacted length of stay and productivity calculations. How did the two of you adapt physician compensation to avoid negatively impacting your clinician staff? Let's start with Derek on this one.
Yeah, as I mentioned earlier, we definitely revamped their targets, and because a lot of it's RVU models based on productivity. So I think our providers were happy about that. However, we did notice in the beginning we had to over-communicate, and that was very important for our clinical leaders. So we set up a daily call where we literally went through our dashboards, and we had to revamp our dashboards as well. And one of the best practice strategies there is you should look at telehealth and virtual visits as a separate service line. It's here to stay, and it's something that the providers, they were getting a lot of misinformation. And so a lot of times we're getting calls about payers should be paying us for telephone consults as if it was a face-to-face visit. And what we found was that many payers said the right thing in public. However, when we submitted the claims, that was not always the case. So we had an increase in denials. So what we did was we literally met with the clinical leaders on a daily basis. We set up a group email to allow providers to submit their questions. And this is the one I had the most trouble with, but I literally gave our clinical leaders my coding manager's cell phone number because it was important for providers to have an outreach to understand what was going on with some of their visits. And a lot of our issues at Memorial Hermann in the beginning were related to some of our issues with technology. It was the first time we actually used our virtual visit platform. So in some cases, even though most of the patients were self-pay, doctors were spending time seeing these patients, but in some cases, the technology had issues that did not allow us to truly get paid for those services. And so we had to constantly keep providing doctors with up-to-date dashboards. And just in general, we provide them with a monthly dashboard. But during COVID, we actually allowed them to have real-time dashboards so they can actually see exactly where they stood The other thing we were concerned about was physician burnout, and then, of course, protection as frontline leaders. So when you look at an urgent care, for example, and you have a potential for maybe even an MA or front desk person being exposed, we had to come up with a plan B, C, and D. And so because of that, we started the thought of cross-credentialing some of our contracted physicians in Houston. And so just to give you a perspective of that, we're roughly about 800 employed physicians, but we're over 3,000 contracted physicians. So we were getting ready for cross-credentialing to make sure that we've had backup to make sure patients could be seen. Thank God we didn't necessarily need those providers, but those kind of strategies you have to put in place because you got to have enough people on the front end to be able to see the patients. And then finally, we leverage IngeniousMed because when you have an inpatient and you have the potential for multiple providers to see a patient, you want to make sure the right doctor gets the credit in terms of who actually saw the patient, who should be billing for those services. So overall, there's a lot of challenges there, but I would pretty much say that the important thing for us at Memorial Hermann was making sure we over-communicated to our physician community.
Thank you. Dr. Durrell, what is your perspective on this question?
Yeah, thank you. Thank you, Lynn. Well, first of all, we usually target for our hospitalist about 18 patients per 12-hour shift. By being able to look at IngeniousMed and know exactly how many patients had COVID, we adjusted that target down to take into account the time that it takes to don and doff PPE, the extra communication that we asked our hospitalists to do with family members that could not visit as part of our normal workflow. And so being able to see that in a dashboard allowed our physicians to feel like we were appropriately lightening their burden based on the work that they would have to do. Secondly, we did use virtual visits even for patients in the hospital to reduce exposure. We have over 2,500 providers across the U.S. We were very fortunate to have not that many providers get COVID themselves, and that was because we did early on provide a platform where they could do a virtual visit, and also if they were seen by other specialists, they wouldn't have to do a face-to-face in-the-room visit. And in IngeniousMed, we were able to bill for that as well, and to quickly bill for critical care time, which many of these patients required, again, inside of IngeniousMed. And so it really became fairly seamless, and we were able to gauge the burden on our doctors and also keep them protected.
Thanks for sharing. That's great insight. So let's move on to the second topic. I'd like to spend a little bit of time discussing strategies for optimizing revenue at the point of care. So let's move in. Capturing revenue right at the point of care is critical to financial success. The impact from COVID on volumes and revenue was significant in the spring. How are both volumes and revenue rebounding in your organizations, and what do you predict for the remainder of 2020 and beyond? Derek, let's start with you.
Yeah, thanks, Lynn. You got to understand Memorial Hermann in the beginning. So when it came to inpatient services, it was a paper process. Our EMR does not interface to our inpatient services. So in many cases, we were dependent upon the provider to bring in face sheets, bring in a piece of paper, and that sometimes could be weeks, sometimes can be months. And so as a group, we made some tough decisions. For example, we actually had penalties that were associated if you did not put your charges or get your charges in within a 10-day time frame. That being said, we did realize as an organization that as far as COVID, we were not getting back to the pre-COVID levels. So we did see recently that we were about 80% back. But there is a certain segment in Houston that I feel that probably will not come back in terms of until we get a vaccine. And so I do not expect Memorial Hermann or any other organization here in Houston to see those pre-COVID levels again until we get a vaccine in place. What we've also seen here in Houston is the job market plays a major role. So when you start thinking about patients, then a lot of times, and particularly underserved communities, they may have certain symptoms that they do not act on because now they do not have insurance, they're unemployed. So we do see that there's going to be some volume issues. Probably it's going to last early into the 2021 timeframe. And we also have seen a lot of spikes. I know, for example, my son went back to school about 3 weeks ago here in Katy, and so because of that, it's just natural after you have holidays and multiple people together, and I think a lot of people have cabin fever. I know I do. It's very difficult to always do the right thing all the time. So because of that, we think that there will be another spike in Houston anyway. And I feel like you have to look at it that way too, because Dallas is different from Houston, and I'm sure the same is for most states. And so if you look at where you live, you have to look at the closure rates and the availability of restaurants and things like that, because in Houston, we have recently started back opening up certain restaurants and things of that nature. And what that tells me is that we're probably going to have additional spikes, especially with the flu season coming in a few weeks. So with all that being said, I'm probably a little bit more pessimistic than Dr. Durrell. But I think the thing for us is to stay the course, stay focused on the goal, and make sure that we have all the proper safety measures in place for our patients.
Thank you. Dr. Durrell, could you share your strategies, please?
Sure. Well, I mentioned our volume drops on the ER side about 50%, hospital medicine side about 35%. We felt that there was a contingent of chronically ill patients that would avoid the hospital for a while, but they would not be able to ultimately stay out longer than about 6 to 8 weeks. So we had projected into May that our hospital volume would be back, and it was back, and it maintains back. In fact, our hospitalist volume is at about 5% above its budget or our baseline. Our emergency volume is still down approximately 15%, and I expect the emergency volume to stay down through the remainder of the year, if not into the first quarter of next year. And I expect the hospitalist volume, again, not maybe hospitalist census, but our hospitalist work to maintain being above budget for the rest of the year and obviously next year. I do think that we saw influenza drop off the table when face masks and social distancing and quarantine and lockdown occurred. And if you look at the curve, it really dropped in March, and throughout the spring, where we usually see more cases. And therefore, I think going into the fall, we will probably see less influenza due to all the measures. And if we get lucky with a vaccine for influenza, that is, if it hits it, then I think we'll have regional outbreaks. There's no doubt, but I don't anticipate another large surge in the fall. In terms of capturing, billing at the point of care, I think for us, we had to cross-credential doctors in markets because we knew we would have some doctors that would be quarantined or might get COVID or be asked to stay home for the 10 days originally it was. And therefore, it was helpful to use one common platform. So if they moved across hospitals, they were still using the same billing platform. They knew where to go to bill. They could bill their virtual visits in it. They could bill their critical care in it. And that made it pretty seamless for us, for all of our cross-credentialed doctors.
Great. It's really interesting to hear you two with different perspectives on the future outlook, and regional impacts will likely be different. So that was a really interesting conversation. Moving on to the next question. There's a critical need for organizations to optimize revenues given the current margin pressures. We talked a little bit about cross-credentialing earlier as a tool to manage surge and help with capacity management. Beyond that, what strategies help to make it easier for you to leverage resources across other areas they are less likely or less familiar with on a temporary basis? Let's start again with you, Dr. Durrell.
Yes, well, I think the key there is understanding the burden, understanding the census on a real-time basis, number of COVID patients, number of total patients in each market and across each hospital in those markets, so that we could utilize a system to staff per volume per day. And so whether we staffed down or staffed up, we were able to have an accurate measure on a daily basis. We did use a call system for some clinicians, so they were on Jeopardy call. We would pay them to be available, and if we had to call them in, then we would. That was very helpful because as volume came back, it was pretty volatile. So it didn't come back in a smooth curve. We had certainly some sites come back faster than others. We had some hot spots, particularly near Chicago. We also have ER practices in Houston that were very, very hit by their spikes as well. And I think for us, it was being able to take a look in real time at each hospital, each census, understand how many COVID patients, and that allowed us to move our clinicians from one place to another where we needed them.
Great. Our third topic today centers on ways to optimize reimbursement. Derek, how has the pandemic changed your payer mix, and how are you optimizing reimbursement given those changes?
Sure. One of the things we saw was we definitely saw a slight increase in some of our Medicaid patients, but one of the biggest issues, again, for Houston and Texas as a whole has been our uninsured and our underinsured patient population. And because of that, I think all organizations must have a comprehensive self-pay strategy. And what that means is you have to have something that allows patients to first even enter the door. And so I think it's wise for organizations to look at online payment options to allow patients to be able to go online, make payments, and get a lot of these services paid sometimes in advance. The other part, which is a big issue right now in Washington, of course, is the price transparency issue, is being able to have prices out there that a patient can understand. And if they can't, I think our organization should also have patient advocates, someone that's able to explain some of the in-house payment arrangements that can be done. But with our organizations, not everyone can make those payments. So you must have a financing option for patients too. And Memorial Hermann, we actually looked at Care Credit, and they were actually a partner, which allows some patients, not all patients, but some patients to be able to have a financing option to be seen for needed surgeries and services they need. In some cases, it was insurance bearing, but at least allow patients to become able for those services. And then I think the last piece of that is you got to have a value-added business partner, aka collection agency, and you have to have someone that meets your culture. There's a lot of agencies out there that doesn't represent necessarily the culture and the way an organization would collect on these balances. And one thing about Houston is we're used to tragedies. You say that with Hurricane Harvey and et cetera. We have to make consolidations for our uninsured population because sometimes it's just temporary, but patients still need those services. So we try to do everything we can up front to allow them, A, to get in the door, but B, also pay for their services in a reasonable manner. We were fortunate here in Houston that we did have a process through Optum, which allowed us to submit claims for our self-pay COVID patients. And again, we utilized IngeniousMed for that piece because it quickly identified some of our inpatients who had a COVID diagnosis, and we were reimbursed for that, which would have been, in some cases, bad debt. So that was extremely helpful for Memorial Hermann. And then finally, I think it's the clinical documentation. It's going back to the basics again, where you have to make sure you got the appropriate diagnosis codes. You got to make sure the services are documented. A lot of patients have comorbidity, even though they may have issues with COVID. And then the modified usage. You know, if a doctor is performing services that are actually separate services, you need to bill accordingly. So I think for us, it was a combination of making sure that we cover everything to get a patient in the door, regardless of their financial situation, but also make it comfortable for them when they left the healthcare setting as well.
Great. Dr. Durrell, what have you seen in the last 6 months?
Yes, well, we saw, older patients did increase. I think everyone's aware of older patients being more severely affected by COVID. And so we saw an increase in older patients, so an increase in Medicare. We saw a severe decrease in pediatrics. In fact, some of our pediatric hospitals had abysmally low volumes. and you can understand why people were avoiding the ERs in that setting. We also saw a increase in Medicaid and then a relative decrease with commercial insurance. Primarily, we believe because commercial insurances were very adept at creating virtual visits very quickly, and patients seemed to be pretty good at that, and that was preventing, some patients from coming into the hospital, and that was obviously very helpful for them. For us, because things were pretty frenetic, and we're in a lot of markets, and as I mentioned, they moved across hospitals. For us, it was important to not miss bills. One feature of IngeniousMed is every day how many bills were missed. So if a clinician didn't put in a bill, we can catch it and we can remind them to do so. And that can be difficult when you have a lot of fast-moving clinicians across multiple hospitals. And then finally, we're in the process of changing our coding process, and so we have been doing aggressive education with our clinicians because they've had coders that kind of go behind them and really look at every single detail. And we're kind of moving to more of an audit function. And so we've been educating our doctors. And the master coder function inside IngeniousMed is a really great way to remind clinicians based on what they have done, their decision-making, the elements of their visit, what is the appropriate code for that. So that's been very helpful in our education process so that we code and document as accurately as possible.
Thank you both for that insight. That's great. Staying with you, Dr. Durrell, what tactics have you used to identify COVID-19 patients and prevent them from negatively impacting your bundled payments program metrics?
Yes, well, that was very interesting for us because we got into BPCI Advanced in January of this year, and we weren't sure what was going to happen. Certainly, CMS came up with 3 options that I'm sure everyone on this call is aware of, but essentially you were allowed to stay in the program this year as is. You were allowed to stay in the program and remove your COVID patients, or you could just have a push for this year. So you would essentially initiate no cases this year and resume in January of 2021. So you can imagine that we needed to know exactly who had COVID, how many patients did, and begin to factor that into our tracking of our patients in BPCI Advanced. And so it really helped us with the flags in IngeniousMed. We knew every patient that had COVID, and so we could cross-reference claims data, and we were able to look at that and make a very good decision on what we were going to do for this year for BPCI Advanced. And it was invaluable to have that insight.
Yeah, that's a good way to stay nimble in these changing times, so thank you for sharing that. COVID posed a lot of challenges for the healthcare industry, but it also created an opportunity to innovate. So I'd like to just ask you to kind of share how that has impacted your decision making. So Derek, let's start with you. In what ways have you used healthcare technology in innovative ways over the last 6 months?
Yeah, some of it things that we had put in place even before COVID. A good example is with IngeniousMed, we were leveraging the system to work some of our edits prior to coming over to our practice management system. We still kept our practice management system as a safeguard, but we were able to identify some of the issues up front in terms of coding errors, and it also lent itself to our provider audits. We really had a tremendous focus on providing more provider education. It's something that we hadn't done for years, and we were trying to use good data to be able to support that. You know, one of the things I love to do, and my clinical team did as well, is it's one thing to tell a provider that they're not doing something well. It's another thing to actually show them the claims that were impacted, in particular some of the reimbursement as well. We definitely utilized our system, our practice management system. We were able to set up the appropriate work lists and functions to be able to identify COVID patients and any other issues related to that, and we had a breakout. So we had our clinical team working certain automated edits, but we also had our practice managers, which is sometimes different for some organizations, but we actually have the front-end staff working some of those edits. And all this lends itself to our Tableau reporting. And again, we go back to the same thing. If you present information, you let people know what's going on. I think most people come to work and they want to do a good job. But if you don't provide the automated edits and being able to show providers, personnel on the front end exactly some of the issues related to that, we did have some pushback with some of our physicians. And so it was, at one point, we brought in a third-party auditor to come in because, you know, you have coders that believe that they follow the rules and regulations. And then you have providers who are actually on the front end who believe they're correct too. But all this lends itself to being able to have an open dialogue that we didn't have before. So we definitely leverage a lot of analytics to drive a lot of our process improvement changes. I use it as a leader to make sure I understood our issues and our bottlenecks and getting claims out the door. But I also use it in our vendor management too, because we had certain arrangements that I had to track electronically to make sure that we were getting maximum reimbursement for a lot of the services that we perform.
Great. Dr. Durrell, how did you use analytics to help you track the value of different therapeutics and treatments for COVID-19 patients?
Wow, well, that to me was the success story for us. I have a background in infectious disease, so I did start to lead a call the second week in March across all of our leaders, our doctors across the country, and it became clear that the science was, we had a big void of science, and it was moving very quickly. We did note early on that patients getting intubated probably could have maybe gotten high flow oxygen or another modality before intubation. And so we actually had our doctors enter clinical notes into the flagged COVID patients. And we asked them to answer questions about early or late intubation. We asked them to note, we were talking about remdesivir in March, although at that time it was compassionate use or clinical trial. We were using steroids in March for cytokine storm and a drug called tocilizumab, and we were looking at also anticoagulation. So, you know, early on, we had to learn from our own patient experience that if we could avoid intubation, and we were looking at the data out of New York, of course, if you were in an ICU and you were intubated, the mortality was 80%. And so we were able to, on a weekly phone call, adjust and follow the science. And also we tracked hydroxychloroquine. As everyone knows, there was discussions about that. I wasn't a huge fan of that drug, but we were able to look at our own experience because our clinicians were documenting for us. And we early on avoided intubation in a lot of patients. We were steering away from hydroxychloroquine. We were leaning towards remdesivir, and we were leaning towards steroids. And then eventually that data became available and proved some of the things we were doing. So it was the early signals that we got from our own patient experience. And we treated over 2,500 COVID patients, and our mortality, despite having a third of patients in the ICU, our mortality was 6%. And so if we didn't have insight into what our docs were doing on the ground, and we could look at it literally every day and look at our mortality data and look at the outcomes and then share it on a weekly basis, it literally saved lives for us, and it allowed us to be nimble and to follow the science and get the information into our docs' hands at the point of care.
What a great success story there. As an engineer by trade, it's really cool to hear you apply technology for you know, with such success. So as we kick off the audience Q&A, and you take some time to think about questions that you would like to pose to the panel, I will move and talk just for a brief moment about IngeniousMed. So if we could move to the next slide, thank you. At IngeniousMed, our goal is to align physicians with hospital performance. IngeniousMed delivers intuitive point-of-care tools that optimize physician productivity and hospital performance. Our easily implementable mobile and web solutions help health systems and physician groups simplify revenue capture, gain actionable analytics, support value-based alignment, and optimize workflow across the healthcare continuum. As I mentioned earlier, we're used in 7 of the top 10 largest health systems and physician groups and process over 80,000 patient encounters every single day across our entire customer base. Our application provides physicians, practices, and health systems unique insights that strengthen revenue and support their focus on improving patient care. So let's begin with our first question. What are some of the best practices for managing productivity? Dr. Durrell, do you want to take this one?
Yes. For us, managing productivity is, first of all, reducing the burden of time it takes to enter charges. One thing that I like about our platform with IngeniousMed is you can bill on your cell phone. And so it's very easy to do. We also use IngeniousMed for our clinicians to document their MIPS answers, that they attest to doing certain of our MIPS measures. And so as everybody on this call knows, MIPS, the penalty for MIPS or reward, which is really more avoiding a penalty than anything, is increasing, approaching 9% now, so of Medicare. So the first thing about productivity is make it easy for your clinicians to bill, to document, and then to document their MIPS measures. And being able to do that on a cell phone as you're moving around the hospital. In fact, when our clinicians do it in real time, not all of them do that, but when they do, then we really have a great gauge of how many patients we have at any time. And of course, that drives the staffing and the flexing. And unless you have insight into that volume of patients, then you really can't flex, and you're basically reliant on a fixed schedule, which is the old way of doing hospital medicine, which we will never do again. So it was really following a staffing grid and having call-ins or flex downs, and then basing that on a real number that was accurate volume inside of our dashboard that came out of IngeniousMed, and that just gave our site medical directors all the tools they needed to really match staffing to volume.
Oh, let me say something
Derek,
about that too.
What are your thoughts on that?
Yeah, the same thing. One of the things I appreciated from IngeniousMed was definitely the physician productivity, because he's right. It drives a lot of our back-end functions. And I think for us, the best thing was it was a culture change for us, because when you start dealing with remote staff, and that's what we had to do. We had a lot of billers, collectors, coders working from home because of the child care issues. And what I found very quickly was not everyone can work successfully from home. And so when you have a way to track the productivity, which is important, but I'm a firm believer that you track productivity daily. And I'm going to give you a good example why. We had a particular collector who one day checked in with 3 patients worked for the entire day. And so we immediately started researching that, and we found out that she logged in at a certain time, and then it was like a blanket of nothingness, if that's a word, for about 6 hours. And then we found out later that she wasn't available because her and her mom went somewhere. And that's the mindset you got to have for your back office staff, because the physicians are working hard to get these patients in. They're trying to see the patients, and we're doing them a disservice on the back end if we're not making sure these claims are coming across, they're being billed out timely, but also we're doing an appropriate follow-up. And so what we implemented at Memorial Hermann was truly a peer pressure kind of thing, where we had a dashboard by groups. So if you were a biller, you saw how you compare it with your peers. And even though you're working remotely, and we had some staff working still in the office, we were able to compare the two. Now, we did have to change a lot of workflows to accommodate PHI and making sure our patients' information was protected. But one of the best things about Memorial Hermann was we did everything on our power not to do any layoffs. So during that time, we were flexing staff. We were doing things to make sure that people still had a job, even though they had to potentially take their time. But what they did also was put us in a situation where we might not have optimal staffing levels. As I mentioned earlier, we were already down 40, 50 plus people. But the productivity monitoring became the paramount issue for us because when staff work remotely, you have to make sure you can gauge what they're doing. As the old saying goes, if it's not measurable, you can't say that it really happened. So you have to make sure you have the right protocols in place.
Great, thank you.
Yeah, Lynn, I'd like to tag. Lynn, could I tag one more on to that?
Absolutely.
Just very quickly. Yeah, and I just think it's so important. When you talk about compensation or productivity with your clinicians, or even the burden of patients that you need to see per day, or optimal number, clinicians inherently remember their worst day, or they remember their worst 6 hours. And so for us, being transparent and having dashboards where they can literally see our targets for productivity, and then they're either red, yellow, or green, and we're able to factor in our nurse practitioners and PAs as a part of their productivity. And Ingenious Med has a way to link a doctor with a nurse practitioner, and then you can look at their productivity and how it's affecting and helping the clinician, the doctor. And so for us, another thing that's so important is for them to say, well, we're seeing so many patients today. Well, actually, here are the numbers. Here it is every day. Here it is every day, and you can see it, and it's transparent. That really gets everyone on the same page, and you get out of the kind of debate about how many patients people actually saw.
Yeah, that makes a lot of sense. Thank you for adding that on. So I think this next question is for you, Derek. How are health systems thinking outside the box to find additional cost savings and value?
Yeah, I kind of mentioned this earlier. It's truly about having good vendor partnerships. Ingenious Med is one that for us, again, it gave us so much latitude with a limited staff where I didn't have people literally having to sit at a desk and enter charges from paper. So that was number one for us, was being able to have a mobile device to allow our physicians to feel comfortable that they can enter charges at any time. It's also important for us to take a step back again and make sure that everything that we have in terms of relationships with scheduling optimization, a lot of organizations do not even have like wait list functionality. And I look at scheduling optimization as a revenue slot. So what that means to me, if someone cancels a service, you should be able to quickly, especially now with a lot of people at home, replace that revenue slot with someone. And are you doing that on a consistent basis? And are you tracking the progress that's related to that? So a lot of that still ties into revenue, and I'm glad Dr. Durrell brought that up, because we do feel that a lot of physicians, and I had this happen before, would call me and say, hey, I saw X amount of patients. I don't see the revenue. I don't see it on my dashboard. So those kind of things can help us talk through some of those issues.
Great. Dr. Durrell, do you have something to add here?
Yeah, for us, as I mentioned, our cost is our clinicians. It's our workforce, and our revenue is our patient volume. So, we obviously have infrastructure staff. There's no doubt about it, and cost there. But the majority of our cost is our labor, and therefore, for us, it was absolutely matching the labor staffing to volume. That was the key for us. Many of our hospital partners are struggling. I guess I would say we're losing some revenue because we have had an increase in some patients leaving if we had an increased wait time in the ER, and we are seeing our partners struggle with nursing staffing. Everybody is. So I think that's another thing, that if we can get our nurse staffing back, which I know is a huge challenge, then I think it'll help us with some of our bed flow issues that we've had throughout this challenging time.
Can I add on real quick? I know it's limited on time. Just a couple of things that does stand out from a revenue cycle standpoint. We have to make sure that we're utilizing potentially bot technology Anything that's repetitive that requires a human to do, we should look at automating, as well as batch workflows. Anything that you can do from 270 to 271 to get eligibility and benefits early on, automated, as well as the 276 and 277, which allows us to standardize the workflows, is a cost savings for the organization.
Great.
Yeah, and Lynn, let me add one more to that. Just so important, the data feeds that we get from hospitals that flow into IngeniousMed that populate our patient lists, those data feeds are invaluable. And secondly, in our BPCI program with our convener, we're able to flow also the patients that are in BPCI. We know who they are, and we're able to flow that into our software for our convener as well to track them over 90-day episodes. And also, we were able to look at our length of stay for patients that were waiting to be tested for COVID to be placed in a skilled nursing facility. So knowing those patients every day, which was another flag we had, all of that was really helpful in terms of data flow into IngeniousMed.
Great. Let's move on to the next question. How did new types of communication with patients lead to better billing outcomes during COVID? And this one could be for either of you. Derek, do you want to go first?
Well, for us, go ahead, Derek. You take it.
Okay. So from a perspective, again, from Memorial Hermann, it was the opportunity for us to get ahead of the game in terms of communicating to patients up front, making sure they understood all our technology tools. It was a matter of us being able to almost promote our services. And I talk about that a lot because we really lean hard on our practice management system to improve. I mean, you come to a point where, what we used to do was great, but we had grown so much at Memorial Hermann that we started looking at every aspect of our processes from reporting to technology. And, of course, we had to also have more of a digital relationship with our patients. So all of that come into play. So I think overall it's one of those things that you keep doing and you never stop doing.
Yeah, I think that for us, the challenge was a lot of our CEOs asked us how we would communicate with families who could not visit the hospital. And it's difficult to do in real time in terms of getting them on the phone. We actually now are rolling out an app actually that I helped develop that actually allows, it's called MyDoc Replay. It's an app that allows the clinician to record a small part summary of the visit and share it in a HIPAA-compliant way with their family who couldn't visit. So we're in the process of rolling that out now, and our challenge is really communicating with families and keeping them in the loop. That's been our issue.
All right, great. Let's move on to the next question. How capable and nimble would you say most hospitals and health systems are when it comes to quickly developing a telehealth service line as opposed to handling it by department?
Yeah, that's a great question. I think one of the issues there is having a proven and tested partner that has done it before, that's embedded hopefully in your EMR. I wouldn't say it's always easy, even if that's the case. It's truly a matter of being able to do a lot of testing up front and try to avoid some of the things I mentioned earlier on that we experienced at Memorial Hermann because it was our first time. And I think now it's almost standard that you have the right technology tools in place to make sure our patients are being seen appropriately. So that's critical. I can't say it's always easy, but it's definitely critical to do the testing up front.
Yeah, Lynn, I found some hospitals were pretty nimble and were able to do it very easily and very quickly. I found some that were not. We introduced some telehealth platforms of our own. We always had to make sure that we were integrated and we fit with the strategy of the hospital when we did that, however, and we didn't want to compete or step on their platforms and their programs. But, the thing is we use a lot of telehealth today for some ICUs, for stroke patients with neurology. We do it for some psychology, psychiatry. And hospitals that had those in place ahead of time, they did much better. And, the ones that didn't were a little bit behind. But again, we also looked at some outside technologies from our company, telehospitalist type functions too, that we could bring to the table if the hospital did not, have the infrastructure to do it.
Let's stay on one more telehealth question. What challenges are you noticing with patient access functions with the rise use of telehealth?
I can tell you one thing we've seen. It's truly about, I hate to say this, but it's about the internet speed for some of our rural areas and local surrounding areas. It's very difficult in some cases, even some of our employees who are working remotely, is to keep the connection and being able to have the updated information for the process to happen the way it should. And so that's the biggest thing I've seen is I think we're proven and tested so far. We know we have a good platform in most cases, most organizations, but you still have to have a certain amount of bandwidth, right, to be able to successfully have the visit.
Yes, I would agree with the Wi-Fi issue. I would also say, I wrote a book with the NFL about healthcare, and when we talk about, when TV came about in the NFL, you obviously were going to get television audience, but you were going to lose live audience. So they wouldn't be going to games. And really, hospital systems have to think about this, as you trade certain other visits for virtual visits. For us, particularly on the ER side, that's a loss of ER volume. That's not necessarily a bad thing, but I think you're going to be eroding into one or the other, as I mentioned in the NFL analogy, and you just have to be aware of that strategically and plan for that.
All right. Well, thank you so much, Dr. Durrell, Derek, for spending time with us today. Thank you to the audience for spending this hour with us. Really interesting and insightful commentary here. And with that, I'd like to pass it back to Abby to wrap us up.
Awesome. Thank you guys so much. That is all the time that we have for today. But again, just want to thank Lynn, Dr. Durrell, and Derek for that excellent presentation, and also to Ingenious Med for sponsoring our webinar today. Attendees, we hope you enjoy the rest of your day, and we look forward to having you join us for future webinars.